being on time on the different countries that we were going to start this webinar. I want to thank everybody that is participating for being here and for being part of this fourth webinar in which we will talk about infections in orthopedic oncology surgeries. I want to thank also Dr. Eduardo Botello. He is the president of the Latin American Musculoskeletal Tumor Society, for being a moderator and for helping us. I guess that Dr. Valerae O, that was our other moderator, is having some kind of trouble because of some problems with weather in the US, but probably she will try to be here. I want to also thank our participants, Professor Michelle Ghert from McMaster University, Dr. Luis Aponte Tinao from Hospital Italiano de Buenos Aires, and Dr. André Mathias Baptista from the Hospital of Orthopedics and Traumatology from the University of São Paulo. So, well, let's start this meeting. Please, Michelle, if you...
Okay, thank you. Is that good?
Yes, perfect.
Great. Well, good morning, everybody. Good evening, good afternoon. And wanted to thank Juan for inviting me to talk about infections and megaprostheses. And I will try to keep on time, but there's so much to talk about, and I'm hoping to have a good discussion as well. So, as we know, sorry, it's not advancing. Infection and megaprostheses are very common, and they are complex and devastating complications requiring many surgeries often end up in amputation. So how common are these infections? A systematic review showed that at least 10% of these cases end up with an infection, a deep infection. And in fact, it may be higher than 10% because of some prospective data that I'll touch on later. So it could be up to 15% of our patients suffer this devastating complication. And so we deal with every day, how do we prevent these infections and how do we treat them? And these are very complex issues. And fortunately, they were tackled very aggressively in the second international consensus meeting on musculoskeletal infection, which was organized by Javad Parvizi. And this second round, which completed in 2018, he invited a oncology group, which was new from the previous meeting, so that we had a large group of orthopedic oncologists to work together to answer the questions, understand the evidence, and to interpret the evidence on how to prevent and to manage infections in megaprostheses. I was fortunate to be very involved in this process, so I have some insight as to how the process worked, but also to talk about the conclusions. And even though there are some published data for you to read, it's quite long, so I'd like to provide a succinct summary for you. The next two slides, this slide and this slide, show that there were 13 steps in this process of trying to answer questions in our field related to infection in endoprosthetic reconstruction. Beginning with identifying the delegates, identifying questions, ranking them, doing a systematic review for each question, putting the document together. And finally, we met together in 2018 in the summer. We sat down together for 3 days. This is the Orthopedic Oncology group. And we worked through the evidence. And this was in the days where we could sit in a room and, hello? Sorry. We could sit in a room without masks and we could amicably argue about how to interpret the evidence. And it was a rigorous process, but in the end, we came to some conclusions based on the evidence and also our collective interpretation. So it was a very thorough process. So the information I'm about to show you is not just my opinion, it's the opinion of our colleagues internationally. The topics on prevention included prevention as well as treatment. So there were different focuses on different days. There were a total of 30 oncology questions that were answered. And for all of them, the evidence was either limited or moderate. So very, very little evidence. The moderate evidence was based mostly on the arthroplasty literature. However, we were able to come to conclusion and consensus just based on discussing. So 100% was based on consensus. And you'll be relieved to know that I am not going to go through all 30 oncology questions. I will review those that are most relevant to endoprostheses and those that are most salient to bring forward to your practice going forward. So the first one I'd like to discuss is the question came up, is there a correlation between operative time and the risk of infection? And if you're operating for longer, do you need to give patients postoperative antibiotics longer? So the consensus was that there actually is no evidence to support prolonged postoperative antibiotics in orthopedic oncology patients. However, if the case goes on past 3 or 4 hours, 2 half-lives of the antimicrobial, intraoperative dosing is needed. So this was the consensus, though there was robust discussion on this topic. Some of you may know, and I know some of you did participate in the parity trial. Well, we were hoping to publish this study in this year. We're in the data analysis stage. And this was a prospective study evaluating 1 day or 5 days post-op antibiotics in these cases to determine if we really do need to go out longer for these longer cases. So that data is not available yet, but will be coming later this year and provide some insight into how long we need to give patients antibiotics post-operatively. When we're operating, should we take into consideration things like radiation, soft tissue resection, bone resection, allograft, all these factors? Should we increase the duration of antibiotic prophylaxis? So these are 2 cases that are very complex: large soft tissue resection, total femur, an extra-articular knee resection. So these are high-risk cases. Do these cases need longer antibiotics? And the consensus was that there's not evidence to recommend anything other than routine antibiotic prophylaxis. What are the significant risk factors for infection? So these are based on any surgical candidate for any surgical procedure. You have the surgical environmental factors and microbial factors and host factors. There's a very long list of the factors you need to take into consideration for a risk for infection. And these you will see in many patients: comorbidities, body mass index, poor skin coverage, poor hemoglobin or albumin levels. Tibia and pelvis are higher risk, long hospital stay, lots of tissue resection, long surgical time, need to go to the ICU, you need to transfuse blood, postoperative hematoma, and any other need for an additional procedure. So these are intuitive. We know these as surgeons, that these are risk factors for infection. But we were able to synthesize the literature and come up with this list of things to think about when you're speaking to patients about the risk for infection. Okay, so you have an infection and you want to reimplant after a 2-stage procedure. What do you need to do? What metrics should you use to be ready to reimplant? And the conclusion was that you need to make sure, of course, that the infection has been eradicated from the surgical bed. So this should be done through a sterile aspirate. And this was what the conclusion of the consensus, that a wound would be ready for a 2nd stage as long as there is a sterile aspirate. This topic was quite interesting because there's conflicting literature. So the question is, does a type of fixation, cemented versus uncemented, of an oncologic endoprosthesis influence the incidence of infection? So what we found was there's conflicting evidence around this topic. There are studies that have demonstrated superiority with cemented fixation, but others have shown superiority with uncemented. So the conclusion was that you just choose what fixation works for your patient based on the individual case, with no concern for higher or lower risk of infection. Should a silver-coated prosthesis, such as silver iodine, be used for reconstruction of patients undergoing primary bone tumor resection? So this, again, was this topic took quite a bit of discussion. There was a lot of work in the literature research background. And the conclusion in the room is that, yes, silver coating and iodine coating of the prosthesis show good results in prevention of infection. However, I have to say that there were 2 or 3 very strong voices for this in the room. And because the evidence did not indicate harm, I didn't push back. And I think that we just don't know. But the The summary of the evidence, as you can see here, really is just animal studies and retrospective studies. These are fairly weak evidence to determine whether you use a silver-coated prosthesis or not. However, there was enough support in the room for the evidence that this was made as a recommendation. Is a DARE, so we use the expression DARE, but irrigation, debridement, and exchange of modular parts. Is it possible to treat this an acute infection with actually leaving most of the prosthesis in, just washing it and removing the modular components? So the evidence indicates that it is possible to retain the prosthesis. It's a viable option, but only in patients with early infection, with fairly short duration of symptoms. They have well-fixed implants. They have a well-characterized organism that is responsive to antibiotics and is highly susceptible. So these criteria should be met if you're thinking of doing a DARE procedure. What about a single stage exchange for patients with an infected endoprosthesis? Is this possible? Is this successful? There really is not a lot of evidence to support this, but it is reasonable to be performed in patients, again, that meet some of these criteria. So if the organism is susceptible, that the duration of symptoms are short, this is possible. However, it is recommended that all the anchorage components be removed, that none of the implant remains for a single stage revision. And what factors improve the outcome? So you're doing a two-stage exchange arthroplasty and you want to maximize the chance of success. Again, this comes into play with the surgical and microbial and host factors. These should be optimized as much as possible. So for host-related factors, if you're going to do a two-stage and you want to have a success in that you don't end up needing an amputation, treat the patient, treat their anemia, malnutrition, support their immunosuppressive state. And with respect to the organism, make sure the infectious disease identifies the organism and it has the appropriate antibiotics, and be very aggressive in surgery with soft tissue management, soft tissue coverage, and manage aggressively any post-operative complications. So again, there were 30 oncology questions. The evidence is limited to moderate. So what I've shown you is that what we were able to come, there's a 2-year process to try to synthesize the evidence, discuss consensus. This was a truly international effort, and this is our conclusions. Going forward, maybe we'll have more evidence, maybe we'll be able to direct treatment with more higher level evidence, but at the same time, our collective discussion amongst ourselves internationally was very, very productive. And I still use these concepts today in my practice, and I found it the whole process very helpful. And I hope that I've been able to impart some knowledge to you about what the process of the consensus meeting was and what we came up with respect to megaprostheses infection. So the take-home points are that these, as we know, none of us don't know that surgical site infections are common in our surgeries, particularly with megaprostheses. Our recommendations are consensus-based, but is based on minimal to moderate evidence. And really a lot of this evidence was extrapolated from the total joint arthroplasty evidence. We as a group do not have as much evidence as that group does. And every patient should be taken into consideration individually based on the host factors, pathogen, and surgical factors. Happily to say, a DARE and a 1-stage revision can be considered in some patients. So this does save us 2-stage revisions in some patients, which I believe is critical. And hopefully with registry data and RCT data going forward, we'll have some more information. And that's it. Thank you.
Thank you very much, Michelle, for such a nice presentation as always. I would please ask Eduardo if he has some questions to be asked so that Michelle can answer them, please.
For sure. Thank you very much, Dr. Ghert, for your wonderful talk and to show us the evidence. And well, I have one question from Javier Delgado from Valdivia, Chile. And he would like to ask you about if you know about infection, the correlation between infections in megaprosthesis and Trevira mesh.
And the mesh?
The mesh, Trevira
yes.
mesh.
Yeah, yes.
And we had a couple of bad cases using the Trevira mesh, and usually in proximal tibia.
Yeah, so that was also brought up in there's one of the other issues that brought up, that does mesh have an increased risk for infection? And the conclusion was that it's not known, that there's not enough evidence to support that, but the proximal tibia is considered highest risk for infection, so it may be confounded by the fact you're using mesh and you're in the proximal tibia. But any foreign body, I believe, does increase the risk for infection. Anything that a biofilm can form on would increase the risk. So personally, I try to use as much biologic tissue as possible, save as much of the tendon as I possibly can. Sometimes you can even take part of the quadriceps tendon and use that, or tensor fascia lata. I've used that as well. A tensor fascia works really well as a biologic tendon.
Perfect. Thank you very much. And Dr. Kindle, he asks, how long is the duration of intravenous antibiotics for a two-stage revision or until aspiration is negative?
Well, we were using, yeah.
Consideration.
Right, that's a great question. We're extrapolating from the literature from the total joint, but 6 weeks. 6 weeks IV antibiotics, and then aspirate and see if it's negative. And I think that's challenging because an aspirate can be negative and you can still have bacteria, but we can only work with what we have. I think eventually there's going to be some more molecular studies that we could look at. And I know the arthroplasty group, they're looking at certain enzymes that bacteria produce, that they can look for that. So right now it's culture, aspirate, and 6 weeks. And if it's still positive, you keep going, probably 2 more weeks, and keep trying. It's definitely a collaborative effort with the infectious disease service, who will provide support with the type of antibiotics and the susceptible pathogen, what should be used, as well as the length.
Okay. And do you have, or do you use, I mean, a period of time without any antibiotic before doing the aspiration in order to
I would say, yeah, I'd say 48 hours. And I don't really like going longer than that. Yeah.
Okay.
Yeah. I know that seems like a short time, but I do think that it could be cleared. If it's a really raging infection still, it will pick up in 48 hours.
Perfect.
Perfect. Well, I guess there's another one also, Michelle.
Yeah.
Which is, do your findings apply for bone metastasis patients with PGI?
Yes, I think all of these apply. The population is somewhat different in that they may not need as much soft tissue resection. The chemotherapy regimens are generally a little bit easier, but they're older and they're more frail. So it definitely applies to that population. And again, you take into consideration the host factors and the surgical factors. But in my personal experience, and we did not differentiate between sarcoma and metastasis in the consensus meeting, but I find metastasis patients do better. I think it's because there's less soft tissue resection. I think that if you're just doing a bone resection, the soft tissue and the blood supply is a huge factor in preventing infection.
Okay. Well, perfect. Thank you very much, Michelle. Once again, as always, awesome speech. And well, let's go on. And Professor Luis Aponte now, he is from the University of Buenos Aires, and he works on the Hospital Italiano de Buenos Aires. He's the chief of the bone and soft tissue bank. So please, Luis, if you can start your presentation.
Thanks for the invitation. So the purpose of this talk, they asked me to speak about infection in massive bone allograft and how we manage the infection and what are our results. So this is my disclosure. So we know that bone grafts are the second most commonly used transplant material after blood, but it's different the use of massive bone allograft, that this implies a risk of infection, and it's a major cause of failure. That was, I'm trying to show what is our experience, and it's not very different than the big experience that is already published. And so, but I'm going to show you the difference that we find during the years. So this is this paper was a paper, really we published this data in the 2014 Musculoskeletal Society. So we tried to analyze all the massive bone graft. You can see that there are APC, osteoarticular intercalary. Already this data is published. I'm going to show you some data that was not published, and I'm going to show you why. So mainly we have more than 600 massive bone graft. They are mainly in the lower limb. So we don't have viral infections. At that time, we have 60 patients with infections, so it was a 9%. It's very similar to the infection rate for prosthesis. But when we performed the univariate analysis, we found that age was not really a risk factor. We found male was a risk factor. And this is very interesting because it's how we change our approach in the OR and the postoperative antibiotics. Here you can see that during almost 10 years, we give 3 months postoperative antibiotics, and we use conventional OR, and the rate of infection was 21%. Then we changed our OR in 1997. So we perform a clean air enclosure with vertical flow, but we continue for almost 5 years with the 3 months postoperative antibiotics, and the infections drop. But then we change for a minimum of 24 hours, and we don't have more infections because we use for 3 months just one day, or until deep drains were discontinued. So we don't. Here in this paper, we show it's a risk factor to use so many months antibiotics, and it was a risk factor the conventional OR. So this is another finding in this univariate analysis. We found that chemotherapy was a risk factor, and tibia was a risk factor over femur and over upper limb, and we have less infection. We have more infection really. It was a risk factor, the osteoarticular and the APC. So we have less infections in intercalary. But when we perform a multivariate analysis, we only have 4. This is the table published in the paper. That was male, that was here conventional OR, long period of antibiotics, and tibia. You can see in our paper, tibia was the biggest risk factor, followed by the OR and the longer period of antibiotics. So that changed since this paper. We are not giving antibiotics for the period that drains are in the patients, because mainly all our patients have at least 1 week the drains, because we try to avoid to have an hematoma. So nowadays, in the last 5 years, we have just 1 day of antibiotics. We are revising that data. We don't show, there's no more complications with these low doses of antibiotics, but we have the same problems in tibia. So it's a major problem. And why I show you this paper? This paper was presented 4 years later. It's not so many patients. Why we dropped for almost more than 600 to 200? Because these are mainly primary massive bone graft in primary tumors. In the other series, it was a second reconstruction. There are no more APC, and this study finished in 2007. The other paper have 5 more years. So when we published the other paper, one of the reviewers asked to perform a competitive risk analysis, and we have mainly the infections in the first 4 years, so we don't perform the competitive risk. In this paper, we perform this competitive risk analysis, and we have 14 percent of infection. So you can see that some years later we have some infections. And here you can see the curve here that more than 15 years later we have infections. So nowadays we can say that we're between 9 and 14%. That's our really risk factor for infection. It continue. In tibia, it's mainly infection, you can see here, and it's a major problem and a major cause of failure for graft. So what happened with infection? What happened with all these 60 patients that we performed infection? We are able to salvage 11 of the patients. So it was some patients, when we published this paper, we salvaged 11. And nowadays, 2 of these patients were having infection more than 10 years afterwards. And what happened with the 49 infected allografts? So you can see 82% were considered to be failures, 4 were amputations, and 45 patients. We do a second, we resect the allograft, we implant a temporary semi-spacer to control the infection. And after that, 4 patients died of disease with the semi-spacer due to the primary tumor. And you can see here that 17 were reconstructed with the endoprosthesis and 24 with the second allograft reconstruction. But what happened with these patients? So this is an example, APC, an infection in the postoperative chemo. Here's the spacer. We always try to perform a very big spacer. We prefer to have problems with soft tissue with the semi-spacer, not with the second reconstruction. And here's the tumor on the prosthesis 1 year after the second revision. This is our example. It's an intercalary allograft. 1 year after surgery, the patient had an infection. We put a spacer here. You can see that we have more bone. You see here is very tiny. We have more bone here. Very big spacer. So we have an adequate soft tissue for the reconstruction. And this is 10 years after the second allograft with gut function. You can see here that we maintain more bone than the original bone that was in the first surgery. And what happened? This is an example of what happened and what we can perform when we have an adequate soft tissue. This was a 6-year-old boy, a Ewing sarcoma, a very tiny piece here. You can see here a very tiny piece of bone. And the patient, 15 days after the surgery, he went back to his States, well, more than 1,000 kilometers for the hospital. And the mother sent a picture 1 week after the first chemo period. Oh, look, this is the leg of my boy. Well, I should go back to the hospital. It says, yes, come back. So we clean. We have an adequate, we perform always gastrointestinal flap, so the flap was okay. But in this case, we were able to put the vacuum assistance. You can see here, the patient continued with the chemo, and finally it closed without surgery. Just the vacuum was performed to continue with the chemo without the need to further surgeries, only the first debridement that we do, and just change the vacuum in the hospital during the chemo. So this is a picture 2 years later. You can see a good function and no infection. So we try to have, when we have some problems in tibia, in some patients we put the vacuum in the first, just in the after surgery, and some patients we told them that perhaps we have to put it always in the tibia. We don't know really, but we have it in hand, just in case. So what happened with the second reconstruction? I told you we have 41 second reconstructions, 17 endoprosthesis, and 24 second allograft. We have 11 APC, intercalary arthrodesis, and intercalary segmental allograft and articulars. We have infection in 14 patients. This was significantly higher than the early infection. You remember it was 9%. And what is very important that we have half of the allograft had a second infection. So nowadays our approach, we only perform second allograft. It's an intercalary allograft that we can maintain the original articular joint, but not in other reconstructions. We have less infection. You can see only 2 of 17 with the second infection. So we recommend to have a endoprosthesis after an allograft infection treatment. So in summary, our infection rate, and similar of we published, is 9%, but it grows to 14% when you perform a competitive release. So it's a range. We have like more infections in longer periods. The risk of allograft infection is tibia, it's the major risk, and then long periods of postoperative antibiotics, conventional or male. And in those infected patients that a second reconstruction procedure was performed, the infection was 34%, but we have more reinfection with the second allograft. So our choice now is endoprosthesis. Thanks for your attention. So you are there.
Okay, thank you very much, Luis. We know that your group in Buenos Aires is one of the groups that produces the most information on allografts. Well, there's a couple of questions. Eduardo, do you have some of them? Would you like to ask? Luis?
I have one.
Okay, go ahead, André.
Luis, did you compare the osteoarticular versus the intercalary groups regarding infection? Did you see anything different?
Yeah, I told you before that we have less infections in intercalary, but in the univariate analysis, when we put the multivariate analysis, we don't find that. I think we need more patients. That's why I show the univariate analysis and the multivariate analysis. Mostly papers, they ask to don't put the univariate analysis, but when there are papers with univariate analysis, I'm able to compare my results. For example, there's a recent paper of the Anderson, so how much time they put the drainage, and they have male in the univariate analysis and they have chemo in the multivariate analysis, and we have male in the multivariate analysis and chemo in the univariate analysis. So I think we have to share information because there are some risk factors that we don't have enough data, and if you compare papers, most the univariate analysis are similar, and the multivariate analysis, it depends on the numbers. We found that intercalary grafts have less infections. Really, we find only in the univariate analysis. That's why we try to perform intercalary graft in the second reconstruction. If it's an osteoarticular or arthrolysis or other, we put an endoprosthesis.
Perfect. Eduardo?
Yeah, I have a question for you, Luis. Did you compare the number of infection of your prosthetic reconstructions versus your biological reconstructions?
We perform that with other centers. It's very difficult for us to compare our results because when we choose an endoprosthesis, most of the cases have they are going to have a radiotherapy, or there are bigger tumors. They have some other factor, host factor, that's why we choose the endoprosthesis. So it's going to have worse results in the endoprosthesis. But when we compare with other centers, we have similar results. We compare in the past with proximal tibial articular and endoprosthesis around center. We compare intercalary. I think it's not because we have to make how we choose the patients. Mainly in the good responders, not so big tumors, we use allograft, and in big tumors that they have not good response to chemo, or we have soft tissue problems, we use endoprosthesis. So it's a bias if we compare our results. But in infection, I'm talking about infection. In infection, I prefer to have an allograft infected than endoprosthesis. I don't have to take the stem. I hate they were discussing when you take the stem of endoprosthesis. Really, for us, the allograft is quite easy. It's just take a plate, clean, and the closure is easier. We don't have the stem like an prosthesis. That's the only advantage when you take out the infected allograft. But you know, when an allograft is infected, it's very hard to clean the allograft. So we have worse result with infected allograft in a local debridement. In endoprosthesis, we can perform that.
Perfect. And last question, Luis. Paulo Segura from Córdoba, Argentina, your country. He wrote, which is your method of stabilization of big intercalary spaces with short epiphyseal segments? Any experience with the cement antibiotic coated plates?
Well, it's very hard if you have a very small piece of bone. It's easy in tibia because it's stabilized, because the tibial plateau is very wide, so it's stable. But in femur, most of the cases, it's very small. We have to sacrifice the joint. It's easier in the tibia, and it's easier in the proximal femur if you have because you have the head and neck. It's very difficult to stabilize the semen spacer. But we try to put the big one, and in some cases we can put cement around the small piece of bone. That is just. It depends on the case. It's very difficult to have a general approach, but it's a major problem.
Perfect.
Luis, there's another one. They are asking if there's any difference with the size of the allograft. If it's a bigger allograft, do you see that there's more infection, or it has nothing to do with size of the allograft?
It's not a problem of the size of the allograft. We have some it's a problem. We have more problem with the site of the allograft. We have more problem with the tibia. So we have a big femoral resections with no problem, and we have a small tibia with problems. Most of the cases we have problems with tibia when there is an open biopsy and we have to take the previous incision, and we don't have so much tissue, and we have more infection in osteoarticular allograft. In tibia allograft, we have less infection in tibia intercalary, but it's the problem of the size we don't find. It's very difficult to find the difference with the numbers that we have, even with the 600, because when we analyze the bone, it's just 60 or 80 per bone. So the size, we're performing some papers with the size, and it's very difficult to find the difference.
Okay, well, thank you very much, Luis, again for your pretty good talk, and thank you for sharing with us all this experience that you guys have with massive allograft. And we'll keep going our webinar. Now our last panelist is Dr. André Mathias Baptista. He's the chief of the oncology service, orthopedic oncology service in the Institute of Orthopedics and Traumatology from the Clínicasda Hospital of the University of São Paulo. And he also is one of the chiefs of the Bone and Tissue Bank. So please, André, if you may.
Well, hello everybody, colleagues. I'm gonna share with you some of our experience on the microsurgery applications in orthopedic oncology surgery. So I'm gonna show you some cases. And it's very important in the soft tissue envelope to prevent infection. So a little history. It's a really recent technique, the microsurgery. So we have been using relatively recently. I'll go very quickly on the history section because we don't have a lot of time, and I'm going to show you 7 cases of our experience. So I'm going to go quickly on this. So the recent applications of microsurgery are very vast in the medical practice. So from microanastomosis to even urology, otorhinolaryngology, ophthalmology, neurosurgery, spine surgery. So it's a technique, especially in sarcoma, in these sarcoma groups. As we all know, before chemotherapy, all patients were amputated and survival was less than 10%. And in the 80s, with the neoadjuvant chemotherapy, we were allowed to try limb salvage. So it became the standard procedure, and the progressive development of our surgical techniques. Nowadays, here at our service, we can salvage about 80% of the limbs. Europe and the United States, it's about 90%, so most of the cases. And how to increase the indications for limb salvage? How can we preserve the limb of the patient? If we have good response to chemotherapy or even radiation in sarcoma, for example, or soft tissue sarcoma, we are more inclined to go for limb salvage. And the development of reconstruction techniques that preserves an adequate function is paramount for indicating limb salvage. So we have reconstruction basically with megaprosthesis, or as Luis said, the allografts. The Argentinian group has a great experience on bone allografts. And the use of microsurgery techniques also increases the indications for limb salvage, especially in the upper limb, in which an amputation brings a great functional deficit, much more than a lower limb. And I cannot overemphasize the importance of the multidisciplinary weekly meetings, the case discussion and the surgical planning, along with the microsurgery, plastic surgery teams, is paramount in developing these complicated cases, these borderline cases. So microsurgery can help us preserve the limb with vascular reconstruction, with inverted saphenous vein, wrist dorsal veins, or foot dorsal veins, and also with free flaps or rotational flaps. They can rotate, they can put skin, muscle, bone, or combinations of these tissues in order to cover our prostheses or our allografts. And it's very important to prevent infection. Also, the skin flaps can be the scapular, the thigh lateral, arm lateral, and a lot of flaps with perforating arteries. So there are lots of options for free flaps. Muscle flaps, the latissimus dorsi can be used. The serratus, gastrocnemius is very common for rotation. Soleus as well, sartorius, and usually the bone flaps. Usually the free fibula is the most common. So I'm going to show you 7 cases of our experience to show how we can preserve a limb with good soft tissue coverage. Case 1 is a 18-year-old female that had a diaphyseal lesion of the tibia, some soft tissue progression. It was a typical adamantinoma. And in this case, we used the treatment plan was wide margins resection and reconstruction with intercalary allograft with the contralateral vascularized fibula and lateral locking plates. So there are the 2 step cuts we made. There's the allograft and the contralateral free fibula. Immediate post-op, and it healed very well. Pathology confirmed it was an adamantinoma, so 6 months postoperative, normal and symmetric neonatal. It's a perfect case, intercalary allograft with a vascularized fibula. We don't do that as a routine. We do mostly when the allografts fail, but in this case, we did it on the first surgery. Case number 2 is a 15-year-old male, right arm pain after rotational trauma. It was in the emergency. Nobody suspected it was a tumor, but on the CT scan, you can see the bone matrix here. So nobody saw that. And it was treated conservatively with a cast until the tumor revealed itself. And it took a lot of time for him to get to us. So when he got to us, it was like that. He did pre-op chemo, had a partial response, and we went for the limb sparing surgery. He didn't have any mets at the time. It was an osteoblastic osteosarcoma. The treatment plan was resection reconstruction with the vascularized fibula, but not only the fibula. The microsurgeon also took the soleum muscle with skin and medial gastrocnemius flap. And we did an osteosynthesis with 2 lock-in plates. So there's the surgery, anterior approach. Here already without the tumor, but that was the size of the tumor. And there's the harvesting site. And here's is the graft, the fibula with some skin, with the gastrocnemius here and the soleus here. So the muscle involved the fibular head, and it gave a good soft tissue envelope that allowed it to heal with no problem. There's the final X-ray. We can discuss about the osteosynthesis, but we prefer a rigid osteosynthesis. And it went very well. He had a good function regarding considering the size of the tumor. But 1 year post-op, he developed multiple bone and pulmonary metastases. And he unfortunately died of the disease. But we gave him a good function for the remaining life period. Third case is a 26-year-old male. He was horse riding and fell and had a proximal femur fracture. He had an osteosynthesis with DHS in other cervix and a radiographic evolution with bone resorption of the fracture. And there's the radiographic evaluation. There's the fracture, there's the DHS, and there's the progression of the tumor. It was a pathologic fracture, of course. And that's the other case. Nobody did anything. So it came like that to us like that, with a fungating lesion here, with lots of tumors on the medial side as well. Just like that. What can we do? So even external empovectomy is a problem here, because he had compromise of the anterior and posterior regions. So we couldn't use the gluteus maximus flap for closure. So we showed for the microsurgery team, and they proposed a free flap from the popliteal artery with muscle and skin, along with our hemipelvectomy. So here's the surgery. We did an external hemipelvectomy, and then the microsurgeons, you see the tourniquet here, they were harvesting the graft, the flapper, sorry. So here's the dissection based on the popliteal artery with muscle and skin. It is a free flap, microsurgical. And here's the field of the resection, the bladder, and the anastomosis on the external iliac artery and vein. On the 7th day of post-op, he had thrombosis of the flap, so he had to be reoperated, but eventually healed. And he was okay for the rest of his remaining life, but he also died of the disease 18 months after the surgery. But it was a good soft tissue coverage proposed by the microsurgeons, so this case went well. Fourth case is a high-grade sarcoma of the right forearm. It's a fungating lesion as well. These are all borderline cases that we achieved the the limb sparing surgery with the help of the plastic surgery and microsurgery team. So you see this case, it was at the MRI, it was a superficial case, you see. This didn't invade the ulna. So we did a wide resection, and then here's the field after the resection. And the microsurgery team entered with the lateral thigh free flap. It covered the defect very well, so we didn't have to amputate this patient. Fifth case is a 14-year-old female. She had 2 previous surgeries as an enchondroma, and of course it was a grade 2 chondrosarcoma. We had to perform an extra-articular resection of the knee, which is a very aggressive resection in a very vulnerable area considering infection and soft tissue coverage. We proposed a megaprosthesis and the reconstruction of the extensor mechanism with the gastrocnemius and the soft tissue cover with the lateral thigh flap. So here's the resection we had. You see the scars of the previous surgery, transverse incisions, which are terrible. And here's the resection. So here's the femur, section tibia. Here's the specimen, wide margins, very well, but the defect is very large. So here's the gastrocnemius on reconstructing the extensor mechanism. And the vascular pedicle of a reverse flow lateral thigh flap. This wasn't a microsurgical flap, a free flap. It's a rotational flap. And it went very well. The donor side had to do some skin grafts as well, but the soft tissue envelope was of a very good quality. That's the X-ray. And the aspect of the reconstruction. She went very well. And a grade 2 chondrosarcoma, if you do a wide resection, the survival is very good. The sixth case is a 26-year-old male who had a tumor in his left arm. It was a high-grade sarcoma as well, in a very difficult site. You see the MRI on the anterior compartment of the arm. The treatment plan was wide resection followed by the latissimus dorsi rotation flap and skin graft as well, and postoperative radiation, of course. Here's the resection. You see the vascular bundle here. So the resection was okay, but the defect was huge. So microsurgeons entered and they harvested the latissimus dorsi and rotated it under the skin to the reception site. And it was put in the place of the flexors, the brachialis and the biceps. Some skin graft was also needed, but it went very well. You see the radiation therapy marks here. This case went very well. And the last case is also an arm case, a 35-year-old male with an even bigger and more medial tumor. That it was huge, that we would amputate without a doubt decades ago. You see the amount of compromise. A lot of necrosis, very aggressive. It was a synovial sarcoma. So, because it was the upper limb, we tried to spare the limb. So the treatment plan was neoadjuvant chemotherapy. it had a partial response, and we followed with the wide resection. It had vascular, neuro, and muscle reconstruction. So it was a very high-risk case. There's the photos of the surgery. You see the artery and the vein were ligated. You see here. Then the vascular, the inverted Safina vein was put on the artery and the vein. And then again, the latissimus dorsi was harvested and rotated to the site of the flexors, the biceps and the brachialis, with the skin as well. Here's the final result, of course, with some skin grafts on the remaining areas. And this case went well as well. So on the upper limb, we do a lot more effort on maintaining the limb because of the loss of function. So it's very important to have these techniques at your hand. So the messages from this presentation is how can we span the limits of limb salvage? Of course, these are all borderline cases, and the surgical technique that is chosen must be detailed and discussed along with the plastic surgery and microsurgery team. So the weekly meetings are paramount, and the multidisciplinary approach is very important in our specialty. And of course, we cannot compromise the surgical margins, but and we also have to have acceptable predicted functional results, especially in the upper limb. The lower limb is easier to indicate an amputation, but in the upper limb, we can do whatever we can to maintain the limb. And of course, like I said, know when to indicate an amputation, not to do crazy treatment plans just to preserve the limb. I usually say to the residents that that this phrase of Henry Marsh, that it's often said that it takes 3 months to learn an operation, 3 years to learn when to indicate it, and 30 years to learn when not to indicate it. So we're always learning. So with our cases, so especially in this borderline cases. So that's the message and the experience I like to share with you today. Thank you.
Thank you very much, André. And well, I guess we have some questions. So Eduardo, please, you can help us with that.
Yeah, sure, for sure. Thank you very much for your nice talk, André. Beautiful cases. And we have a question here from Dr. Quintanay, and he asked you, do we always require flap for a soft tissue sarcoma resection after pre-op radiation therapy? And moreover, for post-op radiation therapy, is skin grafting enough to prevent wound complications?
Sorry, can you repeat that? My audio is not good.
He asked, do we always require flap for soft tissue sarcoma resection after pre-op radiation therapy? That's one. And the second one, moreover, for the post-op radiation therapy, is skin grafting enough to prevent wound complications?
Okay. When we operate irradiated soft tissue sarcomas, we usually take out the irradiated skin in order to prevent dehiscence and infection. And sometimes it needs a flap, sometimes a free flap. Depends on the site, of course, and the amount of resection of the skin you have to do. But we are very fearsome of doing an incision in an irradiated area. So most of the times you take the irradiated skin out, And the second question, oh, the skin graft. We have no problem with the skin graft with post-operative radiation. There's no problem with that. Once you healed, of course, after 6 weeks, we let them do to irradiate, not before that.
Yeah, perfect. There are no more questions here. I have a question for you, André. In your hospital, who's the one who's doing the microsurgery, your free flaps? Is part of your orthopedic team? Is a vascular surgeon, a plastic surgeon?
At the Orthopedics Institute, we have the hand surgeons that do microsurgery very well. So we use the hand and microsurgery team usually. But sometimes we ask the plastic surgeon to come along when it's a trunk reconstruction, for instance, that the hand surgeons don't have a lot of experience.
And then the same question for Michelle and Luis. And at your hospitals, who's the one who's doing those microsurgery?
We have our plastic surgery team do that. They're outstanding. They're excellent. They're just sometimes a little slow. So it extends the procedure quite a bit. They're not as quick as we are, but the work is phenomenal. So we collaborate often with them.
Great.
Yeah, we have the hand surgeons and the plastic surgeries, and what the good thing that we made that we were able to make them work together. So it's very difficult, you know. Ego is very important here. So when they realize that they can work together, it's easy. So most we ask both if they participate and they have they improve. The hand surgeons and the plastic surgeons are okay in our hospital.
Perfect.
What about you, Eduardo? Who does these clean flaps for you in your hospital?
Plastic surgeons.
Okay. I work with the microsurgery and hand surgeons here too.
Yeah, great. And the last question, André, and about the rehabilitation of these patients. Do you have any special protocol because they have a free flap? How much time do you wait? To start, mobilizing the joint.
Yeah, we have physical therapists in our group, so we usually recommend cautions in the first 3 weeks. That is soft tissue healing, and depends on the case. If it's an extensor mechanism reconstruction, we are more cautious, of course, because of rupture of the extensor mechanism or the reconstruction. So if it's only a soft tissue coverage, after 3 weeks, it's healed. So the rehabilitation is normal.
Perfect. Thank you very much.
Okay.
Juan Paulo, I think we are on time.
Yes, there's only just one more question for all three panelists, which I thought was pretty interesting, difficult to answer, but the question is this. If the resection goes well and you use or endoprosthesis or an allograft, and then you can use the flaps or the skin coverage, and you have an infection, which make us have to take away the endoprosthesis, the allograft, or the flaps. What do you do then? How long would it take for you to amputate the patient if he's not responding for infection? So please.
Yeah, there's no real answer for that, but what is paramount to maintain in the limb is a good soft tissue coverage, soft tissue envelope. Either if you have a prosthesis or an allograft or whatever, if you don't have a soft tissue envelope of good quality, it's very difficult to maintain the limb and to resolve the infection. Is that right?
I
Michelle,
agree. If you do have good soft tissue coverage, there's a lot of host factors. If it's a good patient, you try as many times as you can. It's a sort of a discussion with the patient. How many times are they willing to go through the revision? Some of them just say, I can't take it anymore. I would say at least 2 or 3 attempts in a healthy patient with good soft tissue coverage.
Yeah, in our cases, when in our numbers, we have almost 8% of amputations, mainly because they have some space, there's some recurrent infection, In some cases of infection, when we are not able to control, there are very few cases that is immediately pops up and they have to do chemo. We're not able to wait for more than 3 weeks. They're very strange cases. Mostly when we take out we put the cement space, it will respond, but we have some cases that we have to amputate it because they were not able to have chemo. I think that's the main indication in this patient. When we don't control it, so because we cannot delay the chemo. And I have a question, because nowadays we're giving just one day of postoperative antibiotics. I think it's more a decision of the team, a decision of the closed units that they don't want to give more. You know, they're more rigid in that. So what's your approach now? Are you giving one day, 2 days, or we're giving just 1 day? It doesn't matter if the drain is still in the patient.
I just give 1 day.
And you, André?
What about the drains? Don't you keep the antibiotics until you take your drains
I don't
out?
use drains. I don't use drains.
We use drains, but we use drains, but we don't give more antibiotics. We just put the drain and give 1 day and then take it out. We don't have more problems with it.
And sometimes it's a problem because the infectious disease committee doesn't allow you to extend your antibiotic practice. They say they don't have evidence.
Yeah, so you put 1 day under.
We'll find out.
That's what we're waiting for the answer of the parity.
Yeah, we'll find out.
Michelle will answer that.
By the end of the year, I promise.
Okay, well, thank you very much. We are on time. Thank you all the panelists, Michelle, Luis, and André, for your wonderful work. Thank you, Eduardo and Valerie, for helping with the organization. Thank you, Eduardo, for the moderation and for helping me with the questions. I want to also thank you, Professor Winhager, Professor Ruggeri, Professor Funovic, and Professor Papagelopoulos, which is the ISOLS president, for being present here as all the other members of the board. And I want to call the attention for our next webinar that will be next month, and it will be held by Dr. Hairong Xu from China. And also you should know that we'll have webinars every month. So feel free to join us and feel free to tell all the people that you know that they can join us also. So thank you very much. Stay safe. Have a nice day. Have a nice week.
Thank you.
Bye. Thank you very much.
Bye.